is 12:35. As most of you can clearly see, I am not Dr. Bruce Davis, but I am filling in for him as host today of the Clinical Consultation Network. My name is Michelle Bagby. For those of you who aren't familiar with me, I am the DIDD Coordinator of Behavioral Mental Health Services. So I will be hosting for you today and hopefully can live up to the potential of Dr. Davis. We have a wonderful presenter who also happens to be my coworker and fellow team member, Karen Wills, who is our Director of Therapeutic Services, and she's going to be talking to us today about supporting clinical fieldwork education. So Karen, do you want to introduce yourself, tell us a little bit about yourself, and as always, an interesting fact about you?
I sure will. Thank you, Michelle. So I'm Karen Wills, as Michelle indicated, the Director of Therapeutic Services for DIDD, and I am an occupational therapist. I've been an occupational therapist for 30 years, graduated 30 years ago in May, so amazing. This topic that I get to share with you today is kind of near and dear to my heart, so hopefully it'll be some great discussion following some information that I'll provide. Let's see, interesting fact. Well, I think on a trip to Memphis, my coworkers learned that I am a weather geek, so I love weather, and I have been through a hurricane, I have been through a earthquake, and I have been about a quarter of a mile from tornadoes multiple times since we moved to Tennessee. So,
you're getting all of the good natural disasters.
I am.
It might be following you. You should look into it.
Yeah. Yeah, well, hopefully not. Although, I don't know, I seem to be in the right spot for tornadoes, having the last one just barely clipped where we live in Mount Juliet. So, so that's exciting. The earthquake was in northeastern Ohio when I was in high school. There's a fault line up there, so we've had several earthquakes up there. And, so it's exciting. I can't say I ever want to go through a hurricane again. So, and don't care to actually experience the tornadoes. But, so there you go.
Me either.
Yeah. All right. So I would love to talk about supporting clinical fieldwork education today. And then following some information I'll provide, I would love to I'll open it up for some discussion, sharing. I am certain, although I can't tell who's participating at the moment, that we have some of our very own clinical educators on the line or people that have had that experience. So it's certainly a topic for anyone, whether you're a clinician, whether you are work with an agency in the community. More than likely, at one point or another, you've had some exposure or experience supporting or at least communicating with students. So, all right. So, clinical fieldwork education is a required component of health-related degree programs. So, your colleges and universities, and there are varying levels that correspond with as the classroom learning progresses, the level of clinical education tends to progress as well. So, and some disciplines have a little bit different way that they do their clinical education. So they vary. I can speak to occupational therapy. We have what's called level 1 fieldwork, level 2 fieldwork, and they have varying requirements and varying lengths of time and so on and so forth. And clinical fieldwork education simply very importantly bridges academic learning with real-world experience. Yep. Okay. So wanted to just share a little bit of history. I have been with DIDD since 1994. I started as an occupational therapist, moved down from Ohio, and had provided 2 years of therapy services at Ohio State University, and then completed a master's degree in allied medical professions at Ohio State. And so part of that degree had a lot of components to it, but was an educational component. So I had to do some varying teaching experience as a clinician. So, but when I moved to Tennessee, I started at Clover Bottom Developmental Center, was at the time the only staff occupational therapist, and didn't really honestly know a lot about adults with developmental disabilities. My master's degree was specialized in early intervention, and so I kind of fell into the job. Had a incredibly motivated director at the time, and really determined after a short period of time that it was an area that I really loved. And one of the things I think if you've done clinical education that you hear is that clinical field work tends to provide you with information about what you want to do, what area of practice you want to work in. I would say it definitely does that. It also tells you what areas of practice you don't want to practice in. And so, interestingly enough, I completed voluntarily field work in South Carolina with a developmental facility, and this was actually teenagers and adults, and felt personally, without judgment, which I think is important, we all learn what we like, what we don't like, and what we're well suited for. I didn't feel like this was an area that I could work in, and as I got later in life, I realized that part of that was my own personality of being kind of introverted, but here I am. I've spent all of my career, for the most part, working in this arena. So when I got to Clover Bottom, I was excited to start doing some clinical education. And at that time, and I would think that all three institutions may have had contracts with universities or colleges. So, and at that time when we had the state institutions, those contracts were they weren't centralized. So you could, it was a little bit easier, times were different, and for the most part, schools tend to initiate contracts. You'll see that that's not how we do it now, but that was how we did it then. So it became something that was really important to me, and we built the program specifically in the area of occupational therapy. We had a program, and what I can say is that it became an amazing recruitment tool. So we had a number of individuals that came through as students over the years that then became DIDD employees. And have spent, a great part of their career supporting adults with intellectual disabilities. So, but as the institutions closed, there was, it was an incredibly busy time, and some things happened that those programs obviously kind of stopped occurring, not in all cases by any means, but I know we went for a period of time without OT students in Middle Tennessee at Clover Bottom, and that was just really, I think, some necessity to trying to move through this incredible feat of deinstitutionalization, if you will, helping people move from an institution to the community. And however, with that came the knowledge that, wow, we had this incredible place in some ways, not so much that the place was incredible or what it stood for, but we were able to have a very concentrated amount of training and exposure and support, learning about those things that are very important to the health and well-being of adults with intellectual disabilities. So when all of those individuals began moving to homes in the community and the institution closed, there was really a need to kind of start thinking about how do we revitalize this program, how do we figure out how to make this work so that we can still support clinicians to learn about and be perhaps motivated to work in the field of intellectual disabilities. So there were a few years there where there were some challenges, and then in around 2012, we started to work on a consolidated way of contracting with universities, and that evolved a few times over the years until we came out with a kind of a more, and when I say centralized, it's not that it's directed centrally, it's just it's facilitated and coordinated centrally with a centralized contract that we provide for universities and colleges. So there were a lot of things from a human resources standpoint, from a school standpoint, where we needed to have a standardized contract. And so we spent quite a bit of time developing that and began to provide that contract and work with schools to build a network of schools that were interested in having relationships with our department in all areas of practice. So at this point in time, we have the contract, we have a standardized process. Over the last year and a half, we developed an internal operating guideline, and a number of our clinical educators that have been taking students, had an interest in taking students, gave input to that so that we make sure that we have the same process for every student and support their needs and meet our human resources needs and so forth. So the other thing that we developed was, I guess this has been in place for about 3 years, was I felt the need to develop a registry so that if at any point in time we could see where there were students and what kind of students we had. So it's an easy way to be able to basically track who the student is, who the supervisor is, what school they've come from, what degree they're pursuing, and how long, when they start, when they finish, how long they're going to be with us. So there's been a lot of evolution, in particular, over the last 5 to 7 years, too. And I would say we're at a really exciting point to support clinicians to learn about this unique needs of adults with intellectual disabilities. So our contracts that we set up, we wanted to make them kind of open in terms of, we didn't want just a contract for OT students or a contract with a school that had a PT program. We wanted those to be kind of open, so it allows us, if a school has a nursing program, a social work program, an occupational therapy program, once we establish that contract with the school, we can accept, as long as we have a clinical educator that's willing to provide supervision and work with students, we can accept anybody from any of those programs. So we have everything from occupational therapy to physical therapy, speech language pathology, ironic that I can't even say that, dietitian, nursing, behavior analyst, social work, and hopefully I'm not leaving any out at this point. And And we also have, what I wanted to note is some of the disciplines, in particular OT and PT, have observational requirements. So if they're getting ready to apply to a therapy program, they often have to have pre-program application hours. And so we will support a student to come in and observe for a day. So that's something we do, but it's not required to be a part of the contract. So we have a little more flexibility to have that happen. And occasionally we'll get a student in high school. The high schools have programs now that, I know I live in Mount Juliet. I have one daughter that went through the public school system, and, they had, when they got up in high school, they have more specific areas that they can take classes and coursework in. So we have had some high school students as well. So I wanted to show you a list. Our list of colleges and universities has grown significantly since we kind of began to reach out and establish and then revitalize the contract process in 2012, between 2012 and 2014, and that contract has gone through some evolution. But these are the first set. And I'd say it's pretty well represented across the state. So you can see many of the larger universities. And then something exciting that happened last year was we had one of the things that we did, because it was kind of odd when we were presenting a contract to the school, because that's the standard practice is the school presents a contract to the hospital or the clinic or, whatever it might be. So we used I did a lot of research back in the 2012, 2013, and pulled from the Board of Regents contract to try and make that process a little bit easier. And so it was challenging. Getting the contract signed is a little bit of a challenge in that, typically I will, or one of our clinical educators will be talking with the director of a particular program, but as everybody knows, same thing with our department, that's not necessarily who's going to sign the contract. So it can get a little bit crazy, but I guess about 2 years ago, I worked very closely with Jordan Mullinex. He's our contract manager. And he came up with the idea and was willing to work this process of trying to develop a contract with the Tennessee Board of Regents. And he was successful, diligent in doing that, and was successful. So when that happened, we added all of the schools that you see listed here, plus all of the colleges of applied technology. And I would say we're up to about 40 or 50 schools that we have the ability to take students from. One of the challenges we had was the College of Applied Technology schools. We would get one, and then we'd get another one, so we'd have to amend the original contract, and that kept building. So this was an incredible success in terms of being able to broaden our relationships with state schools and universities and colleges.
Karen, I want to interrupt you for just a second. I know you're a modest person, but you've also done a lot of work to make that Tennessee Board of Regents contract happen. So I just wanted to take a minute to applaud your efforts as well.
Oh, I appreciate that. All right. So this registry that we started, and has provided us with some statistics. And so I just pulled some interesting information from that to share with you. So we started the registry in September of 2017. And so not quite 3 years, but almost, because I'm going to count a student that we have getting ready to start. So, but through that, there have been 70 students. We did, unfortunately, we had some of our first physical therapy students that were going to be doing a rotation in our middle seating clinic, and unfortunately, these were earlier on, so one was in May and one was in June, and at the time our seating clinics have been closed. But the schools, these particular students one of them was a level 2 student, and they require a certain number of face-to-face hours, and there was no way that we could guarantee that given what was, what was going on. And so the school made the decision to cancel that. So unfortunate, for sure. But 70 students over almost the past 3 years. And you can see a breakdown. So OT, we've had 18 students. And that is, we have OT assistants, which are your associate level degrees. We have master degree students and doctorate students. Speech language pathology, we've had 4, and that's a master's degree program. The dietitian, we've had 5, and they've been bachelor degree programs. The nursing has had 40, and those have been LPN associate degree students. We've had 2 master's degree social work students, and we are getting ready to support our first physical therapy student in East Tennessee. So in addition to that, I had the fortunate experience to have was called an experiential. It was a Belmont doctoral program, and it's really kind of like a capstone. So that was actually back in 2015, 2016. And so I had that, and this particular student was great. I'll actually share a little bit of her literature review work because I think it speaks to the need for clinical education fieldwork supervisors. But she actually was very interested in adults with intellectual disabilities. She sought me out as a supervisor, and her program, her student capstone project was based on looking at these factors that motivate their occupational therapists to work in the field of adults with intellectual disabilities. Okay, and then we had another exciting experience. We had a dietitian from Finland that came. She came not as a student or an intern, but she had done completed graduate work, was very interested in working in the field of intellectual disabilities, and got into touch with our regional dietitian in Middle Tennessee. And she ended up, we were able to work through the process of being able to bring her here, and she came and spent 3 months in the United States, and I got to spend a lot of time with her. She actually got to spend a lot of time traveling. She went and spent time with some of our regional dietitians, some of our agencies in the community. She really, we worked to bring her really broad experience. So those are some kind of unique and exciting endeavors that we've had.
Hey, Karen, I have a question. You might get to this in another slide, or this slide perhaps, but are the clinical educators, are they only state employees, like DIDD employees that are in those professions, or does it expand on that?
So that's a great point, and I actually will cover it on this slide, so good question, and it gave me time to drink water. All right, so the 70 students for the last 3 years represent the following things. So there's 9 colleges and universities. There was 13 clinical educators or supervisors through the IDD. So that is the main, so every student has to have a main supervisor that they are working with. Some have, for instance, depending on the discipline, depending on the type and level of field work, most of that supervision, in particular, I can speak to the therapies, is, one-on-one, it's constant supervision. So lost my train of thought on that one, but so 13 supervisors have been in working with those 70 students. And then, excuse me. I'm so sorry. So in addition to the main supervisors, I can tell you how we do quite a few of our students are through our seating and positioning clinic. I think one of the challenges that we've had with therapy students is that, you've really got to have the ability to provide a consistent level of interaction. So we've really tried to get a little bit creative with, for example, regional staff that have wanted to take students to create some experiences that allow them to do that. But our seating clinics are a setting where we've got a consistent kind of caseload, if you will, of individuals. So what we've tried to do is when we have students through the seating clinic, we have taken extra time to set them up to do a lot of different things while they're with us. Particularly, so a couple of our programs, we have a master's degree program at Belmont that we work very closely with, and those students come once a week for, I think it's like 9 weeks, 7 weeks, something along those lines. And then when we get into level 2 students, they're with the supervisor for 12 weeks, so it's a lot longer. But what we try to do is set them up with a lot of different experiences, which does two things. Obviously, it gives the students an understanding and an ability to have exposure to other disciplines. So what does nursing, for an OT student, they can learn about some of the things nursing does with adults with intellectual disabilities, or as a behavior analyst, or a dietitian. And then we also are able to arrange for them to spend time with a agency in the community. So, for example, maybe a day services agency or a residential agency or an ICF in the community or our own ICF. So we will set them up to do a variety of things that they can learn, in addition to taking some of the specialty classes. So we've had students take, for example, mealtime challenges in physical management. We've had students take we've provided a version of person-centered planning or person-centered training. So there's a lot of things that we try to vary their experiences. And that way, the other thing that does is for the regional staff, particularly some of our regional clinicians who don't necessarily have the ability to take a full-time 12-week student, they still get the opportunity to spend time, to mentor, and to provide and interact with students. The other thing that we've done with students that have come through the seating clinic is connect them with a clinician in the community. Because it's one thing to see what DID clinicians do and evolve disciplines, but it's another thing for them to see what a private practice therapy agency or therapist does in the community and the kinds of things they face and they experience every day, the good, the bad, and so they get some exposure to from some of our independent clinicians or small therapy agencies about owning a business and having that experience and how they interact and work with individuals throughout the region.
So I think that piece is a great part of the experience. Karen, do you know, or can you provide any information? Are those clinicians volunteering to be involved in this process, or do you ask clinicians if they're interested, or how would someone interested in doing that? What's the best way for them to be involved?
would love to see us kind of expand now that we've gotten to the point where I think we've got a pretty great group of DIDD staff that are interested in doing this. I would love to figure out a way, maybe you and I and anybody on the phone can kind of indicate how we can get clinicians that are interested in doing that. But what have you done? I think I'm having an allergy. So sorry, hold on.
It happens to me every time I have to speak for a long time, so I'm totally
oh my goodness. It is terrible. So the way we've done it, it's not exactly voluntary, but we will call clinicians and ask them if they are willing to do that. Same thing with the agencies. We'll call an agency. We'll see if they're willing to have a student there for the day and, or part of a day or whatever. And then, of course, we set up things like making sure that the individual is okay with it or their conservator, that they're okay with having a student. But yeah, I mean, I would love to have a pool, if you will, of clinicians in the community, where that would be willing to volunteer and have that. I think it would be great. Some Fieldwork lend better to something like that than others. I don't know if some of the other, I can't speak, if there's a nursing supervisor on the line, they may be able to speak to the fact that that would be workable, but it certainly has been workable for our OT and teaching students that we've had.
And I can speak from a behavior analyst perspective. We would definitely, in order to really facilitate this properly, I think we would have to definitely include clinicians from the community, just because the regional behavior analysts, they do not carry a caseload. So like you're talking about creating those experiences for them and giving them that information and training and that exposure. I think it's great to enlist clinicians from the community. So I think we should definitely get together and brainstorm how we can get more interest or kind of gauge interest in that, as well as gauging interest in other clinical educators throughout the IDD.
Absolutely. And I know we started to kind of explore our East Regional Therapy team is working with the speech language pathology group at University of Tennessee. And one of the things we talked with the professor there about was them reaching out to some of our community providers to establish contracts on their own, which would then further build the ability to have people learning about, in this great area of practice. And it's really a specialty area. So I think that's another next level that I would love to see, which would be exactly that. Because we only have so many people.
I was just going to ask, have you had any experiences that have been set up in the community homes? Has that area been explored at all?
Yes, we have, as a matter of fact, our TT student is going to be we're going to have a 3-week TT student that's going to be with, kind of actually interestingly shared between our regional PT and our community homes PT in East Tennessee. So that would be another creative way, and they did a great job putting that program together and working with ETSU to make sure that they could meet all of the fieldwork criteria. But so they are going to be working some in the homes in East, and then we've done that same thing where we've had students that have been in our seating clinic have spent days, whether it's one day a week, it just really varies with the therapists that work in our own ICF homes. Because again, it's a little bit challenging for them. Their schedules a little more consistent, but varies just like the regional office staff. So it's hard for them, I think, sometimes to take on especially your longer term 12-week clinical stuff.
Yeah, absolutely, and I think that might be a good avenue to explore for enlisting more behavior analysis students as well. We got a question in the chat box from G. Ojafor, who's our Director of Nursing in Middle. Do you know if any of the LPNs came back to work for DIDD after their graduation? Any of those nursing students?
That is a great question. I don't know if Leah McLean or Stephanie Britton might be on the line. They're the ones that have supported, and there's one other person in West.
This is Stephanie Britton.
Hey.
Hey. We have had probably a handful apply. They didn't get hired. It just had to do with our hiring process. And when they graduated and they hadn't sat for boards and got their license back yet. But it definitely has generated interest in the field and exposed some nursing students to a specialty they never thought of going into.
Yeah, that's great.
Great. Thank you, Stephanie.
We also had another comment in the chat box. They just wanted to say that they think this is wonderful. But at RHA, they've actually established a contract with TCAT in Knoxville and have had success with students applying for jobs upon graduation in that realm as well. So it sounds like from a recruiting perspective, this is a great option to get people in the field to stick around.
And I would say to any of the agency staff that might be like RHA that is doing that, we would certainly support having anybody, for example, someone that you're supporting clinically for a student, come and spend some time in, say, one of our seating clinics. I would say that we would love to explore some opportunities just like that. So it'd be a great partnership.
Sure. How can we help each other? Absolutely.
So I have a slide here just talking about some of the benefits, and I'm sure I have missed a number of them, but I just kind of did some of my own brainstorming and pulled some from the research of what has been done around fieldwork. So professional growth is certainly a benefit. It can really boost the clinician's energy. It's something new. It's kind of exciting. It's a way to give back to the profession, especially if you had a great experience as a student doing your clinical fieldwork. And it can also be something where you are wanting to improve on what your experiences were in your fieldwork. I did a rotation when I was in OT school, and my roommate in school and I went to Gulfport, Mississippi, so way out on our own, and we had a 6-week rotation. We swapped, so we had 2 different supervisors, and she had one, I had one, and then we swapped the second 6 weeks. And the one supervisor is great, and the other supervisor likes to disappear. And so my experience was not great there. It taught me a lot because, it was their first time having students, and so it's a way to kind of go, okay, I would never want that to happen with a student that I work with or that our department works with. So yeah, it's a way to stay current with information. Students have access to a lot of literature, a lot of current best practices, and it really kind of goes, both ways in terms of that. It's a way to build and refine teaching and mentoring skills. So, and I would say that there's enough variety in the types of fieldwork that could be available that, people who aren't really comfortable maybe yet doing a full-blown field work, that we can work to accomplish a day, a few days, and build on the comfort level. It's great to have relationships with the college and universities. That's kind of an exciting professional bonus. And I know that some of our schools provide us with access, to a lot of information. So, training, we've had everything from training about being a level, a fieldwork coordinator. And so there's some really nice things that are available in that relationship. It's, just knowing that you're promoting an area of practice that is a specialty area. I've heard so many people present on CCN, and it's so funny because so many say, I never thought I would ever end up here. I didn't think I'd work in this area. It wasn't something I got exposure to, or, this is, but once I got here, I never left. And so I think that is a huge, it speaks loudly to the need to have individuals get exposure and learn about this special area of practice. And continuing education credit. So I know for OTs, our Practice Act supports that depending, you can get a certain number of hours of continuing education for a certain number of weeks or certain types of clinical education. So those are some benefits. And we have some challenges, of course. So again, being unsure of ourselves, time consuming. So if it's done right, you're taking the time to prepare. You may be, maybe that you're developing the program from the ground up. So you're developing manuals, you're working with the schools to ensure that you have learning objectives, that are required, evaluation tools, and so on and so forth. That's gotten a little bit easier because so much of that stuff is online now, and you go in and you rate, and do your evaluation online. So it's from that perspective, that's changed a lot. It can be both intellectually or emotionally draining. I kind of think of it, again, although some people would be surprised perhaps to hear me say I'm an introvert, but I always think of it as you're always on, is kind of how I think about it. And so at the end of the day, not only have you been, especially in a specialty area, like adults with intellectual disabilities, you're thinking through all the interesting things that come about, unique things, and then and then you're also working with trying to supervise and share information, and so it can be draining.
I'm really glad you're pointing out some of the challenges. I think most people on the line have probably at some point trained a new employee, for example, and I think it can be very time consuming, especially if there's not good preparation and just having good awareness of what activities would be beneficial for them to learn and not, inhibit productivity in other ways, or the quality of service that the person might be receiving. So I think it's very important to be aware of those things and develop plans to address those issues.
Yes, absolutely.
And it's also good to have as the supervisor, it's also good to have a mentor or your own supervisor that you can rely on to help, address some of those issues and the emotional aspects that you're talking about.
Yes, for sure. I think there's always a risk of getting a student who either isn't quite prepared or just is the wrong fit. I will say, I think in the years that I have worked with students or know of students, I only think that in OT world, in all the years since 1994, we've had one student that didn't make it through. So, so that's not a typical thing, but it certainly could be, kind of a fear of supervisors or new supervisors. And then decreased productivity, and really that's a different scenario for maybe those of us working in this field, as opposed to, and for example, an outpatient rehab clinic where the caseloads are much higher, and you're seeing way more individuals throughout a day. So it can be something that impacts our clinical providers in the community. Should they take students and work with them, but nonetheless. So, and again, I'm sure there are other challenges for sure.
So in our chat box, I wanted to make sure we got to. Margaret indicated since there's not a speech language pathologist currently in the Middle Tennessee Regional Office, it would make it difficult for clinicians to get observation hours and learn more about the specialty area. How can this be rectified, particularly if none of the community providers are willing or able to accommodate students?
Well, first I would point anyone with that interest in that need to the East Tennessee Regional Team, because they've done some really creative work with UT. And I don't know enough of the ins and outs. So for just a quick example, OT students can be, depending on the level of the field work, can be supervised by other disciplines. So, and can have alternate types of placement that are not like a clinical placement. So CT students have to be supervised at this point. They're a doctoral entry level, all of their programs, so they have to be supervised by a PT. So, depending on the varying levels that an SLP student has, there may be the ability to do some level of work with our community therapists. But like I said, I certainly point anyone interested to that. I can put you in touch with our East team, who again, have done some creative work to figuring that out. So.
Yeah, and I think it's very important to remind people to definitely look at whatever your governing body is, whether it's a licensing board or another board specific to your profession. Most of them have criteria that have to be met for supervised independent field work, and it's very important to familiarize yourself with that, especially if this is an area that you're interested in, because you want to make sure that you're doing things according to those guidelines.
Yeah, absolutely. So I just included in terms of reinforcing the need. This was a piece from my student who did her capstone project with me that was through her literature review, and I thought it was a great piece to identify the need. So individuals with neurodevelopmental disorders, including ID, require supportive health professionals who are willing, knowledgeable, and skilled to address their particular challenges and vulnerabilities in maintaining their health. So, and one of the things that she found through her research, which was a challenging area of research, but the biggest key and the takeaway that I had from her was that exposure is the key to finding and building skills and knowledge and making somebody, identifying their motivation to learn and work in the area of intellectual disabilities. And one of the things that I always tell students is that you may, and this was the biggest piece, that when the state institutions closed, it was so important personally to me to continue the ability to work with students, because, it became even more apparent that people needed to at least have a foundational understanding of how to interact with somebody with intellectual disabilities, how, and just know some key facts. So, what I tell students is, in this day and age, it doesn't matter what field you work in. You can work in, orthopedics, but it is, more than likely you're going to work with adults with intellectual disabilities that have all ranges of, things that they're dealing with. And so, we even teach the most basic things of communicating and, what's going on with someone who's nonverbal. And so those are really basic things, but they can go a long way in making a clinician comfortable working with somebody that maybe can't communicate with them or can't tell them what's going on with themselves. So that's, I think at the crux of how important this program is. And again, somebody else brought up the issue of recruiting, and it certainly has been successful. And I think, as a lot of us have expressed presenting on CCN, it's something that we maybe never thought we would do, or just never were exposed to it. And so once we did, this has been our life work. So if my thing will forward, wanted to end with a shout out. So we, if you saw Open Mind, you will see that we had a therapist, Andrew Hinkle, who is an OT in our West Seating and Positioning Clinic, and he was recognized as the Fieldwork Educator of the Year at UT Health Sciences Center in Memphis. And while it might be a little bit small to read, I put Drew, believe it or not, it was Andrew, and he was supervising Drew. And I asked Andrew, we have just a couple minutes left, so I asked Andrew if he would unmute himself and just share a little bit, a few sentences about his experience being a fieldwork supervisor. Are you there, Andrew? It might be double muted. And may not be able to reach you.
No, so thank you.
And that's okay.
It's not audio connection, you need to click.
Yeah, so anyway, I know we only have a couple minutes left. If there's anybody else that has thoughts, questions, thoughts, comments, any of you who have provided supervision, feel free to unmute yourself.
We'll give everybody a minute. If you have questions, you can definitely unmute yourself and type them into the chat box. In the meantime, I just want to thank you, Karen, for presenting on this. I think this has been a great presentation, and it's been good to learn about the complexities of the history of this process from my perspective. So I really appreciate you presenting on this topic.
Absolutely.
We'll pause for a minute to see if anybody has any questions. Or if perhaps Andrew was able to get his audio worked out. But congratulations, Andrew. On the,
Thanks. Can anybody hear me? This is Andrew.
You can.
I forgot to push *6, so I messed up. Anyways, sorry about that.
So, Andrew, if you want to take just a minute and share your experience, I'd love that.
Thank you, Karen, for everything you've done to help, set up, students here, and I know across the IDD. Your list was great, by the way, because I was looking through every key point there and thinking about how it applied to me. I was really fortunate to have Drew here, and thankfully the name similarity didn't confuse us too much. He came very prepared from UT, so definitely no issues there. And I've had a lot of students over the years, and so my experience has been the students I've had have always been prepared, and I try to tell every student when they come here that they have a lot to teach me too, and it's a partnership more than anything. I also had a lot of help here in the IDD, which is great to see. Lots of people stepped in and shared their knowledge, from the CPM classes and mealtime challenges classes that was taught by Mary Brinkley over here, and a lot of our West Tennessee Homes OT and PTs came in and took Drew for half a day here, half a day there, and got him some exposure that way. Certainly my coworker over here in West, Lena, who's the PT in the seating and positioning clinic, she was a great help. And, when I had some things I needed to attend to, and it was early on in Drew's clinical rotation, he was able to observe her, and that really did help facilitate the learning. So this is a pretty technical, niche-y kind of area here in seating and positioning, so there's a lot of technical stuff to learn, and so that was great. I had a lot of support from Lena too, and it was just a great experience. I've had great student experiences by and large. I really haven't had any bad experiences from a supervisory standpoint, but this was a special one for sure, and said some very nice things about me. I'm kind of joked. I'm not sure I deserve those nice things to be said about me, but appreciated them anyway. So I didn't know that.
Thank you for coming on and sharing that, Andrew. And I might just, twist your arm for maybe a future presentation on your experience as a clinical educator.
I'll be happy to. It's a great experience. I'd encourage anybody. And I think, I guess I've had a lot of students in the past, so I wasn't really, anxious about it, but I can understand why someone would be, a therapist, clinician, nurse, whomever. I would just say anything we do to support people, to take on students, even at some small amount, like a half a day, is really good because you just gain confidence as a supervisor, as an expert. Nobody thinks they're an expert, but they are.
And on that positive note, we are out of time. So thank you both for coming on. Thank you for those who had questions. Thank you, Karen, for this great presentation. And that's it for the Clinical Consultations Network for today. This occurs every Tuesday at 12:30 Central Time, and the recordings will be on the DIDD Clinical Services website if you missed it. So have a great day, everybody.
Thanks, Michelle.